In the spring, I was at a conference for military family physicians, USAFP, a conference I have attended for many years. I was struck by how low morale seemed compared to prior years and how disheartened these docs seemed about medicine in the military. The physicians described grinding out their visits, feeling task-saturated, the pressure of a workload and resource imbalance, and feeling inundated by various and sometimes competing priorities from the clinic, the group, AFMOA, and others. They seemed unsure of where to focus their efforts, shared inefficient workflows they developed to help create margin in their days, and described leaving each day feeling like their care in our system was average at best. It was clear to me that they felt undervalued, overwhelmed, and defeated in their role in military medicine. I left this conference and flew directly to San Antonio for the AFMH Deliberate Planning Team, a group comprised of AFMS leaders and a few of us from the field that were put together to try and brainstorm a restructure of the Air Force Medical Home. Here, I could tell that leaders were also frustrated with the inefficiencies at the provider team level, the lack of standardized work, the lack of 90 appointments even being on the books, much less actually being seen, the disruptions to the clinic schedule, the lack of access, and the perceived lack of motivation and maybe even professionalism at the provider level. Both conferences were full of people convicted to find a better way, but it was evident to me that these two groups were missing each other. I desperately wanted to bridge this gap and could see strong points on both sides, as I'm an administrator by personality, yet still a trench worker in a busy AFMH clinic. I set out to find a better way. I came back to Ramstein and partnered with my amazing GPM and PA, intent on finding a way to satisfy teams, patients, and the metrics. Why did these things have to be in conflict with each other? We were confident that with satisfied teams and awesome access, our patient satisfaction would soar. So after hours of discussions and lots of cocktail napkin ideas, we redesigned our whole system at Ramstein. It started with leadership. It started with a very out-of-the-box concept pitched to our group commander. And he listened. He listened a lot and asked great questions. And then he said yes. He promised us his full support and got fully behind us and fully in front of us. And within 3 weeks of starting the pilot, our metrics, satisfaction, and teamwork went through the roof. And it hasn't stopped. We put passion back into practice, and we'd love to share with you how we did it.
So you've got an access problem, which means you've probably got a patient satisfaction problem, and you've got a provider satisfaction problem. So what do? Well, you've got two options, and they're the top and bottom of the same fraction. You could add more work to each day, increasing your denominator of supply, or you could make the numerator smaller, address the demand. And because you have an access problem, your numerator, is already booked solid, so there's only one place to add those additional appointments, to the denominator, later. But your patients don't want later appointments, they want sooner appointments. You don't need to add to the later, you need to open up the now and the next. In fact, that's what we measure, having enough open appointments in the next 24 hours in the next 7 days. That's access. But how much access do you need? What does that look like on a provider's schedule, in a day or a week? Well, they did the math, and the math came out to 90. But let's talk about what happens when you ask for 90. When you ask for 90, especially in the environment of cross-booking and along with all the other expectations placed on teams, providers create margin by developing workflows that seem efficient for today's care, but are ultimately inefficient and actually add to their future demand. The truth is, patients only create a portion of demand. Provider workflows create the rest. The sum of patient and provider-generated demand is how teams get booked months out. Some of these workflows include booking follow-ups that could have been done virtually, addressing only one concern per visit, or turning TCONs and secure messages into appointments to save the time it takes to explain to a nurse or a patient a plan of care. All of these things fit within the model of 90 per week, but they don't help improve your access or patient satisfaction, and your providers are left working 57-hour work weeks with just 18 minutes of personal time per day. Your PCM teams are incentivized to give you 90, inefficiently. And really, 90 is exactly what you asked them to do. And nobody's happy. So we asked a question. Is 90 really the priority? We looked at what we measure and what we are asked to provide. We ask for 90, but we measure the next third. Let's talk about the next third. On a given day and as a snapshot, Our next third metrics aren't very actionable, but when plotted daily against the number of available future appointments in the next 7 days, we found an interesting trend. We found that some providers needed a different number of face-to-face appointments in order to meet the patient need, even when balanced for utilization and acuity. In fact, some providers required fewer than 90 face-to-face appointments a week to care for their patients. You could call that efficiency. So we asked why. What makes some provider teams more efficient than others? We dug into it. GPM and provider. Instead of being adversaries, we sought to understand each other's perspective. We realized that providers could see demand, but GPMs were measuring supply. For years, we've been focused on the denominator, but our teams with the best access were focused on managing the numerator. But we had problems. The most efficient providers were experimenting with numerous approaches to open up their now and their next for patients. But nobody had the time in their day to consistently maximize all of the most efficient practices. The people who found or created best practices weren't rewarded for what they were doing and were quickly burning out. So we decided to reset Ramstein. Reward efficiency, set priorities, empower teams. We set our priorities. It wasn't the 90 that we cared about, it was the patients receiving timely care, provided by staff who were happy to be at work. We created a balanced scorecard that aligned what we measured with what we asked for. And with the scorecard, teams could clearly see that meeting a patient need was more important than filling up an appointment slot. We viewed our schedule as a flexible tool to meet as many patient needs as we could. Now, not later. Today, not 3 weeks from now. And if PCM teams could be efficient enough to manage their patients with fewer than 90 traditional appointments, that was rewarded. We empowered teams. We cut out those traditional appointment slots that they had proved weren't necessary, and they used the time to get ahead of demand. We asked the ones in the trenches to innovate, and boy did they innovate. The teams created an entire scrubbing protocol within Alta that enabled real-time, continuous virtual huddles. They figured out a way to unlock the true potential of telemedicine with a more efficient virtual appointing system. The teams created a vetted priority access clinic, removing the uncertainty often inherent in the open access concept. The GPMs came up with transparent metrics that helped staff capture the work that was done in a meaningful way, creating a shared sense of accomplishment, a cohesive team concept, and, this is key, passion. And most importantly, we rewarded our teams for their efficiency. A reward creates value. Value increases motivation, and motivation breeds innovative, driven, efficient staff. We recognize that we have historically given our highest performing teams more work in the form of cross-booking, DUMPs, and additional duties, and that isn't rewarding at all. So we stopped doing that. Because for us, being efficient doesn't mean there's less work being done. It means that the right work is being done in a smarter way. And if teams met our tailored scorecard goals, a concentrated 4-day work week could be guaranteed every week. And our staff satisfaction went through the roof. We also found that patient satisfaction dramatically increased, likely because we could spend more time with them, address more of their concerns in each encounter, and always much sooner than ever before. But more than that, our patients noticed and consistently commented on how eager the staff seemed, how happy we were. Happy staff, happy patients. And we definitely experienced what all the top healthcare organizations already know, that the more confident our patients were that they could access their PCM, the less they called. So you've still got that access problem, and you're wondering about how we actually fixed ours. First, we created the environment. Listen, cross-booking is bad for access, and it's terrible for provider satisfaction. We get it. Cross-booking's assumed first-order effect is improved short-term access. But its proven second-order effect is a reduction of access in the long term, because it incentivizes all of the inefficient practices that lead to reduced access. Cross-booking is a Band-Aid that lowers the bar clinic-wide to your least efficient PCM team. Emphasizing ownership of a patient population raises the bar as high as your most efficient team. At Ramstein, teams own their patient population. Next, we didn't tie virtual encounters to one 10-minute appointment slot, which would have limited the time we could spend on an encounter. In fact, we didn't put them on the template at all. We knew that we had incentivized efficiency enough to drive the use of them as a flexible tool, and we found that when patients were given the choice between sooner care and scheduled care, they chose sooner care almost every single time. Finally, we gave teams the white space they needed so that we could look at every single patient on our schedules, as far out as they were booked. If there was a way that we could care for that person earlier than their scheduled appointment, we did it. Once a week, we ran a prioritized open access clinic. Some people we simply walked into our day. Some we brought in for a tech-run CSSP. Some we brought into a nurse-run clinic. And some we just called and refilled their Claritin. For about 3 weeks, the appointments rebooked. But then, the magic happened. We reached the bottom of the pile of demand. And because we didn't cross-book into those open slots, they stayed open. In fact, 60% stayed open, so we deleted them from the template for good. And what happened when we reset Ramstein? What happened when we gave teams a 4-day work week with 10 templated appointments per day? Well, our access hasn't moved above 2 days out for a future appointment since we started. Our ER utilization rate has dropped by 25%, and our no-show rate has plummeted from 8% to less than 3%. Even with the massive reduction of templated appointments, we still have an 8 to 12% unbooked rate. So maybe we did miscalculate. Maybe 40 appointments a week is too many. And most importantly, now that we have reset Ramstein, our staff is happy. Our patients are happy. Our leadership is happy. At Ramstein, we're happy.
By now, we hope you're asking yourself the big question, can I replicate these results at my medical treatment facility? Sure. In fact, absolutely. Here's what you need to do going forward, and it starts with you. It starts with leadership. The culture of reset is transferable across all organizations. It is a fundamental ideal of revitalizing squadrons. Set clear priorities. Start asking the right questions. Listen to your teams, and then align the answers you get with what you emphasize at your facility. Empower teams. Give them the latitude to innovate, support them, and be a cheerleader for the good ideas they came up with. And then watch them fly. And when you see your team gaining efficiency and transforming your organization, reward them. Put passion back into practice.